Okay, I'm recording.
All right.
And Pleasant Hill CERT program, Unit 4, Disaster Medical Operations. Last Wednesday, we talked mostly about triage. We've got a lot more material to cover. And I will try to make it more interesting than I did last Wednesday. However, there are no promises. So you've seen a lot of this slide before. We want to do the greatest good for the greatest number of people. And that really is especially true when we're doing triage. If we don't do triage right, well, then we're not doing the greatest good for the greatest number of people. We always hope for the best and plan for the worst. We should be doing that, planning for the worst, which would be a severe earthquake, of course. But the equipment that, or the equipment that you should have and the training that you have, you can use any day you're faced with any sort of medical emergency. So here's our objectives. You can read the slide as well as I. We're going to get a lot into treating injuries. Okay, here's our public health considerations. Again, you can read that. We'll talk a little bit about purifying water. Okay, we want to wash our hands frequently using soap and water, and we want to wash our hands for at least 20 seconds. That's been drilled pretty much over the last year. That's been drilled into us. The way you can count 20 seconds without looking at your watch is sing happy birthday to yourself. If you're in a public restroom, maybe do it quietly. Non-latex gloves, I recommend a neoprene. Those are the most common. That's what you find in the hospitals. You can find neoprene gloves. Any hardware store has them, Ace Hardware. Now here on this slide, it says 1 part bleach to 10 parts water for 30 seconds. I've got something I want to add to that. First of all, what type of bleach? There are different types of bleach available. The bleach that is normally used for your home use in your washing machine is a diluted bleach. And so it's recommended that you have 8 drops of this common everyday regular bleach to 1 gallon of water. And you let that stand for about 30 minutes. If after 30 minutes you don't have any chlorine odor to the solution, then repeat it and wait for about 15 minutes. If you get too much bleach, and it has a too strong of taste, you got too much bleach, then what you want to do is you want to mix it back and forth between two containers that have been cleaned.
Mike, can I interrupt for a second?
Yeah.
The proportions that you're talking about in the audio, the 8 drops of bleach per gallon, that's for disinfecting drinking water.
That's correct.
Right? And what we're seeing on the screen, I think, is for disinfecting gloves. Is that correct?
What I'm talking about with the reason I'm talking about 8 drops in 1 gallon of water is it's for drinking, but it's also a disinfectant. The reason that I bring that up is because we have a diluted bleach at home, and that 1 part bleach to 10 parts water for 30 seconds is for a stronger bleach. So that's why when I'm talking about the 8 drops in 1 gallon of water of regular bleach, which is what you're gonna probably encounter. Now, I'm certainly, if I'm in error there, well, then next week you can certainly correct me on that. Or you can do research while we're talking. And I'm certainly willing to accept another version.
Yeah, Mike, too, you're correct with 8 drops per gallon, or if a gallon of water is too much, two drops per quart. That's for drinking water.
Okay, and if the water is contaminated with a chemical, adding bleach is not going to make it drinkable.
Right.
So you got to be careful where you get your water. We're all familiar with the N95 mask, right? That's because it's been drilled into us over the last year, since the 16th of March last year. Keep dressing sterile. You do the best you can in a survival situation. But the most dressings that you get, they're in your first aid kit, for instance, they are sterile until you open the package. So once you open the package, you want to try to avoid handling them too much. And if you handle them by a corner, you're not going to place over any wound. And we've seen that slide many times. If it's wet and sticky, it's not yours, don't touch it. Sanitation. Waste products and plastic bags. And if we may not have the authorized, inspected disposal device for bacterial sources. So a substitute is a plastic bag inside a plastic bag, which is something probably that was more applicable to us as CERTs than a bona fide government inspected disposal device. We want to bury and bag human waste and make a map, take notes, so you can give that to the appropriate FEMA people so that they can dig it up and do something with it. Disaster medical operations. Okay, here we go. We do triage, get through triage, and the next thing is transport and treatment. We may be able to do treatment where the people lie. We want to choose a site that's going to work adequately for what we need, which would be the immediates, the delayed, the walking wounded, and a morgue. And we want to make sure that we have a good location that's going to be safe for us and for the victims. And if we can, we want to try to place it in a position like you can see on the slide here. That's pretty nice. We have a clear day, it's not raining and the wind's not blowing, and it's daytime, and it's right near a street where ambulances can show up, but that may not be available to us. So we want an ideal situation. That would be wonderful. Have it situated where you got plenty of room for the victims that you've encountered and you've transported, but maybe room enough for expansion. There may be some victims elsewhere that could be transported if we have a better location. And we want to have wheeled transportation, whether it be a pickup truck, a van, or an SUV, or under ideal situations, a fire department or an ambulance of some sort. So we want to be upwind from any hazard. I've already talked about being accessible by transportation vehicles and it being expandable. It doesn't have to be outside. If this is an earthquake aftermath, it depends on how severe the initial earthquake was, how much damage was done to structures. If we have easy access to a structure that is has modern engineering and has only felt light damage, then we might want to choose to have our treatment area indoors. We have a lot more control. The treatment area may be used daytime and nighttime. It may be winter time and weather may be cold. We don't want to have to worry about hypothermia in addition to everything else that we worry about. So there's something to consider. It doesn't have to be outside. So consider an indoor treatment area. And make sure if it's outdoors that we're not putting it underneath a big tree that may have loose limbs, or some things could be falling off of the tree. Here's an ideal treatment area, something we can shoot for. Naturally, we want to transport immediates to a higher level of medical care, but that may be the immediate and the treatment area that we establish. Depends on how severe the emergency is. Okay, here we go. RPM. If we do triage, we're not going to be transporting. We want to get through triage so we can do the greatest good for the greatest number of people. We want to reach those people maybe later in our triage that have immediate needs. And you remember respirations, RPM, respirations, no panting. If they aren't panting but they're breathing, then they pass respirations, they pass R, move on to the next step, which is perfusion. That's your capillary refill, check for perfusion. 2 to 3 seconds of refill. If it's in excess of that, well, then they fail perfusion. If they pass that, well, then you move on to mental status. You can do it all pretty quickly as you approach the victim. If you say, I'm Mike Houston, I'm from the government, I'm here to help, and they giggle at that, well, then obviously their mental status is pretty good. You can say, show me your right hand or show me your left hand, and if they produce their right or left hand, well, you know their mental status is good. You can check for perfusion, and you can tell whether they're panting. So it can be done pretty quickly. You want to move on to the next person. If they fail respirations, you classify them as immediate and move on. If they fail perfusion, classify them as immediate, move on. If they fail mental status, classify them as immediate and move on. Okay, but we don't do transport, we don't do treatment when we're doing triage. And what type of injuries are we about? Are we gonna encounter? Life-threatening injuries, bleeding, breathing, shock. I would suggest you consider doing what I do. I approach somebody, even if their mental status is good and they don't appear to be bleeding seriously, and then I'm gonna lay them down. And as I mentioned last week, the body loses heat much faster through the ground than through the air. So if you have the victim on the ground, a blanket or a jacket or something underneath them is worth 2 on the top. Different types of injuries. You can read that as well as I, and we will address some of those directly. Okay, head to toe assessment. We can't, obviously, because we're in Zoom, we can't do that hands-on, so that's going to be a little bit difficult to teach about that. But first thing you want to do is you want to approach the person if they are conscious, tell them that you're trained in first aid, give them your name, ask them if you can provide care. If they can't provide consent, if they're not making any sense, or they are unconscious, well then consent is implied. And you can conduct your assessment. If the victim is a child, hopefully they'll have a parent or guardian with them. The consent, and a child is under 18 years of age, consent has to be provided by a parent or guardian. If there's no parent or guardian available, well, consent is implied. If life-threatening conditions are present, you provide care. With adult victims, if they have provided consent, they can deny consent after you've begun, and you have to stop. With a child, if you have a parent or guardian that has provided consent and they suddenly back up on you, well, you have to stop what you're doing. Okay, so conducting head-to-toe assessment, we want to get permission, we want to explain who we are and how we're trained. Whenever you're giving treatment, you don't ever want to exceed your level of training. My level of training is probably a little bit greater than yours because I've taught advanced courses in first aid, but I've forgotten a lot of things, so I might go back to the basics. So don't ever exceed your level of training. Conducting the head-to-toe assessment will determine what type of treatment is needed. You know, you can actually do a head-to-toe assessment, pretty good head-to-toe assessment, without actually physically touching the victim. You can have, for instance, injuries to the shoulders, to the muscles of the shoulder, injuries to the clavicle. If you ask them to raise their shoulders, you can ask them, where does it hurt? There's a set of questions that I use, and they're called sample questions. And I think I usually teach this in the class. And I use the abbreviation sample, SAMPLE, sample questions. And S stands for symptoms or signs. If you don't see them, you can ask the victim if they're conscious. You can ask them, well, you know, what's going on? Where does it hurt? What happened? A stands for allergies. Do you have any allergies that might contribute to the symptoms that you're experiencing? Medications. Are you taking medications that you either have been missing, or you may be taking more medications and they could be causing some of these symptoms? Has this ever happened to you before? That would be the P, prior happenings or past medical history. Last time they ate or drank. If they're feeling lightheaded, it may be related to a blood sugar level. Last time they ate. L stands for last time they ate or drank. And E stands for event. What happened? I mean, if you didn't observe it, maybe they could describe to you what happened. If they fell off the ladder onto the concrete patio, how was the ladder? 3 feet off the ground, or 6 feet off the ground, 18 feet off the ground? You know, anything above 6 feet off the ground, you're going to expect a head, neck, and back injury. And what was the mechanism of the injury? What are the totality of circumstances? This can all be done verbally. The hands-on physical exam was quite a bit more complicated than that. You have to start at the head and work your way toward the feet. You want to maintain a good dialogue with the victim. If they are conscious, they need to tell you if what you're doing does it hurt? Where does it hurt? How does it hurt? We have to be really careful what we're doing. We want to make sure that we don't add to their injuries, and we want to be documenting whatever we're doing so that we can refer back to that. Although you may get victims that have already received triage, it might not hurt to do RPM again that just because somebody, and I mentioned this last week, I mentioned it in other classes, if they're the walking wounded and they came to your voice before you entered the structure, let's say, it doesn't necessarily mean that they are always going to be in that kind of physical condition. I mean, if they had a blow to the head or if they have internal injuries, it could become significant a little bit later. So maybe you might consider doing RPM again if you're in the treatment area. The hands-on physical exam, you start at the head and you work your way to the feet. With children, you want to do toe to head. Primary reason is that they're probably pretty shook up about the whole situation. They may not know you, and they're unfamiliar with what you're doing. They've been taught by their parents not to talk to strangers. They're stressed out. Combination of things. If you start at the head, that could be pretty threatening. So we advise that you consider starting at the toes and work your way to the head. And by the time you get up around their head and neck, well, maybe they've gotten used to what you're doing and they've gotten used to your voice. Something I often forget is look for some sort of medical identification around the wrist or around the neck, that they may be diabetic, they may be allergic to certain medicines. So look for that medical identification. We can want to get a tag, or we want to somehow annotate the victim with what we've done and what we've determined. I mentioned sample questions. Look, listen, and feel. And they do have a right to refuse treatment if they're an adult. That looks like a pretty friendly situation, doesn't it? Okay, here's some symptoms of a closed head, neck, and spinal injury. You can read that as well as I. I'll try to add a few things to it. One of the things that that may be quickly obvious to you would be either blood or pinkish fluid coming from the nose or the ears. That indicates an internal injury to the head. Bruising behind the ears may not show up yet. Raccoon eyes, again, bruising around the eyes may not show up right away. Uneven pupils, you may not notice that unless you use a little pen light, and you can flash across the pupils, and you may see whether they actually respond. Uneven pupils, it would have to be pretty obvious, with one being much larger or much smaller than the other. Seizures could be a sign of head, neck, or back injury. They could be a sign of something else. Okay, anytime that we are doing a head to toe, anytime we're transporting a victim, we always want to minimize movement of the head, neck, and spine. Want to keep it in a straight line as best we can. I don't know if you've ever seen the EMTs or paramedics respond to an emergency in an ambulance. One of the first things that they do is they put the donut around the victim's neck to stabilize that. That helps them minimize the movement of the head and neck. And they do that religiously. It doesn't matter what type of injuries this person has encountered. If the EMT or paramedic is treating this victim, they're going to use that donut. One less thing for them to worry about. Okay, treating burns. We want to remove the victim from the burning source or the source from the victim. We'll get into that a little bit more with chemical burns. if you're in a campfire and if you're at a campfire and let's say you inadvertently put your hand down on a stone that's been next to the fire, well, you're going to remove yourself from the burning source. But we don't want to, anytime we are treating a burn victim, and if we're quickly on the scene, first thing we want to do is remove the burning source or remove the victim from the source. Cool the burn area if possible. Always loosely cover with a sterile cloth any burn to reduce infection risk, which we're always concerned with. And if possible, if it's an extremity, elevate the extremity higher than the heart. No ice, no antiseptics, no ointments, no butter, nothing, none of that stuff on the burn, because by the time you get advanced medical care, they're going to have to remove everything. Now with the ice, it kind of depends on what type of burn you have. If it's a third layer burn, then you're not going to use any ice. If it's a first layer like sunburn, you can use ice, but remember, anytime you're using ice on like a swelling or a sunburn, that sort of thing, you always want to make sure that you have some sort of barrier between the ice and the victim's skin, because we don't want to make the burn worse than what it is by freezing the skin. Extra caution with infants, young children, the elderly. We elderly just don't deal with these types of emergencies very well. And infants and young children, the same. They don't deal with the effects of the burn as well as normal and as well as adults, as long as they're not elderly adults. Make that clear. Okay, chemical burns. You can have liquid chemicals or you can have powdered chemicals, dry chemicals. We do want to flush with lots of cool running water, but before we add any water to a burn that has been created by a dry chemical, we want to brush away as much of the chemical as possible, because the dry chemical may be reactive to water, which would make the burn worse. So we want to remove the clothing, want to remove the dry chemical, whatever the cause of the burn is. If it's a liquid chemical, then we're going to be flushing with lots of cool running water for at least 20 minutes. When we're brushing the dry chemical away, brush it away from you, or brush it away from the victim, brush it away from any innocent bystanders. Don't brush it onto a table that's nearby that you're liable to put your hand on. You're never going to brush all of it away, but brush away as much as you possibly can. And then you're going to want to flush with copious amounts of cool running water. Cover the wound, the burn loosely with dry, sterile, clean dressing, and then you want to transport to advanced medical care as quickly as possible, because you may, just all the flushing of the cool running water may not do everything that we want it to do. So we want to get as much advanced medical care as possible. Inhalation burns. You know, I've talked about mechanism of injury and totality of circumstances. If you've determined that there are chemical burns on an arm or a leg or on a torso, chances are you're not going to have inhalation burns, right? So that's determine what the totality of the circumstances are and the mechanism of injury. If it's been an explosion, then there's a possibility if a person is close enough that they've got an inhalation burn. Sudden loss of consciousness may or may not be related. It could be the impact from the explosion itself. could be impact from a flying object. And if there is evidence of respiratory distress, upper airway obstruction, it may be a burned airway. That's what we worry about, the swelling of a burned airway. There may be burns around the lips or on the tongue. There may be soot around the mouth or nose. As I say there in the slide, maybe singed facial hair, burns around the face or neck. If you got burns around the face, well, then there's probably a reasonably good chance that you've got a upper airway inhalation burn. Not much you can do about this. Be prepared possibly for CPR. Get them to advance medical care as quickly as possible. Okay, wound care. Primarily with wound care, we want to control the bleeding. That doesn't mean that you're going to be able to stop the bleeding. You may not be able to stop the bleeding entirely. We want to control the bleeding. So remember that, control the bleeding. We want to control the bleeding by direct pressure. That works in almost every case. We want to clean wounds, so we obviously don't want to scrub, and we don't want to create more damage. How are we going to clean the wounds? The best way to do it actually is with warm soapy water. Some people want to use alcohol, and it's gonna hurt if nothing else. It can do damage if you apply alcohol over a period of time. We don't want to use hydrogen peroxide except on very kind of superficial wounds, scratches, abrasions. That's fine, but the problem with hydrogen peroxide, it not only kills the cell walls of bacteria, it also kills cells, good cells on your body. So any serious wound, we're going to avoid hydrogen peroxide. And when we talked about tourniquets last week, and if you were listening last week, Jim made it pretty clear that we're not going to be using tourniquets unless you have extensive training, approved training. So that's why we've highlighted it here in red. No tourniquets, no hydrogen peroxide. Believe me, you can control almost every type of bleeding with direct pressure. It may take a lot of pressure, but use direct pressure. You go ahead, like I said, clean the wounds, don't scrub, apply the dressing to the wound. Now, if it's a very, very deep wound, or let's say it's an open fracture, which goes deep into the body, you want to be careful about cleaning it. You want to clean maybe around the wound and control bleeding, but you don't want to introduce foreign matter into a deep open wound, because that's going to create a problem later on. Infection, something we worry about. We're probably going to have to worry about that a little bit more unless we can get a victim to advanced medical care like a hospital or a clinic quickly. But if we're in a survival situation, earthquake damage, that sort of stuff, well, then we want to be pretty concerned about watching for infection. Normally, we are not going to apply a dressing over a wound and then remove it later, because when you do that, if the wound is beginning to scab up, when you remove the dressing, you're liable to remove that healing process. But if we're in a situation where you're not going to get advanced medical care for many hours or maybe even a day or two, you might want to consider every few hours checking that wound for infection. any type of wound is going to show some sort of inflammation around the wound itself. What we worry about is that inflammation spreading, that discoloration, which is going to be normal around the wound somewhat. If it starts spreading, and one way you might be able to tell is initially taking a pen and outlining with dots maybe, or little lines around the inflammation, and see how much it grows. If you get a lot of discharge from the wound, or you start seeing pinkish following some of the surface blood vessels, the veins going back to the heart, well, then we've got a serious infection problem. We want to try to avoid that if we possibly can, but we can check for that. Okay, if we have some amputations, this is really concerning minor amputations. It might be a tip of a finger, a piece of an ear, maybe, that sort of thing. We want to obviously control the bleeding, treat for shock if you can, do that every time. Save any tissue parts wrapped in a clean cloth or put into a baggie, place in a baggie with a patient's name, date, and time. If you can, keep it cool. I don't know quite how you're going to do that. You can, if you can apply some ice around it, but not directly on it. Maybe not even, you don't want to freeze it. So maybe rig up some sort of way of keeping it cool. And you want to keep it with the victim with safety pins if you got them, or duct tape. Impaled objects. We do not remove impaled objects. We want to immobilize the body part and or the object. For instance, you should have a picture, an X-ray picture in front of you showing a nail going through apparently a thumb. We don't get out our claw hammer and tell the victim, I'm trained in this. This is going to hurt a little bit, but I'm going to pull that nail out for you. We don't want to do that. That's not our job. You're going to be doing more damage. Certainly hurt. It's going to hurt like hell. So we want to immobilize that object. Maybe even immobilize that body part, depending on what body part it is. So the rule is we don't move it, we don't remove it, we immobilize it, control any movement of it, control bleeding. And we might, it depends on what it is. If it's a hand or an arm, we can do the sling. That would help to immobilize it. And you all have received excellent training on how to make a sling. Fractures, dislocations, sprains, and strains. How do we tell the difference between a fraction, a dislocation, a sprain, or a strain? Now, some dislocations may be really obvious. Most sprains and strains are not really that obvious. If you have an open fracture, that's going to be obvious. Or if you have a fracture where you've got a movement of the bone under the skin and the skin hasn't been broken, that might be obvious. But generally, you don't know the difference between a fracture or a sprain or a strain. So we're gonna, since we don't have access to an X-ray machine like the doctors do, then we're gonna treat them all the same, right? So how do we determine a fracture, dislocation, sprain, or a strain? Well, there's gonna be, maybe a victim could tell you, it hurts right here. Tenderness, restricted use, these are all things that your victim can help you with. When you introduce yourself, you tell them you're here to provide them help, and with this is what I'm trained to do, what happened, where does it hurt, they can probably help isolate what the problem is. So our objective is immobilize where the injury is. We do that with any means that we have available. We're going to get into that in the next couple of slides. So I would recommend that we always treat it as a fracture. And we're going to be using whatever is available for splints. So what's the idea of a splint? That's to immobilize and to support the injured area. So before we get started, we want to check for color, warmth, and sensation. So that after we've done our job, we can check for color, warmth, and sensation again to make sure that we haven't cut off circulation ourselves in our effort to assist this victim. So we're always going to splint the injury in the position you find it. And based on experience that I've had on in the past with the National Ski Patrol, I've never found a serious injury where in a position that was impossible to splint. People have a tendency to move that injured part of their body into a position that's most comfortable for them. You know, our job is not to try to realign the bones. Our job is to immobilize, support the injured area, any means we have available. There in this picture that shows that they've used 4 triangular bandages, and that looks like a pillow to me. You can use, let me go back to that. You can use blankets. You can use magazines rolled up. You can use cardboard. Cardboard is nice because you can cut it to the right size. You can double it, triple it to give it stiffness. Magazines are pretty good for maybe the lower arm or the ankle. Blankets, towels, large shower towels. Be innovative. Just use it in a manner where you can get the best use of whatever value it provides. Obviously, in that picture, that arm isn't as mobilized as immobilized as it could be if you were using cardboard. But if that's all you have available, then you can really cinch down on those 4 triangular bandages and make that pretty firm. And with the way it's wrapped around that arm, you're not going to have any problem with cutting off circulation. Okay, all I can tell you here is on dislocations, the slide on dislocations, don't try to relocate. You're not trained in that. You want to immobilize in the way you find it. It's not going to be fun for the victim, but you're not trained in relocating it, so we're going to immobilize, treat it as if it's a fracture. I would treat that as if you're in a survival situation, treat it as a fracture, immobilize it. You can't really tell. You could still have a fracture and it would look just like that. Here are the different types of fracture. The displaced fracture over on the right there, that's the one that may show up without puncturing the skin. It could show up as an odd shape to the arm, but you're still gonna, it's not your job to relocate or replace it in position. It's your job is to immobilize it in that position. Okay, open fracture can be pretty dangerous. An open fracture can sever arteries, so you may have a real serious bleeding problem. If there's foreign matter, dirt or foreign matter around the opening, you can't be using soap and water because you'll be introducing foreign matter into a wound that goes deep into the body. You can brush off around, be as safe as possible, as careful as possible. Brush off around the wound any dirt that you can. Control the bleeding. Use plenty of dressing to help control the bleeding. And then you're going to splint any way you can possibly do that. If you can, place moist 4x4 dressing over the bone end. But the biggest thing to worry about here is the bleeding. You may be lucky, it may not be bleeding real seriously. You can go ahead and do that moist 4x4. The primary thing is you want to control bleeding, and then you want to immobilize. Obviously, do not try to draw the bones into the tissue. And I already talked about it. Don't irrigate the wound. Don't want to introduce foreign matter. Nasal bleeding, bloody nose. Don't put your head back like my mom taught me because she didn't want me to bleed on the carpet. We don't want blood to go down into the stomach, and that can make you nauseated, even if it's your own blood. Pinch the nostrils together, lean forward. It should, if you have a reasonable platelet level in your body, it should coagulate in about 10 minutes. Even if you're taking blood thinners, it should coagulate in about 10 minutes. Maybe even give it 20 minutes. It should coagulate. But if it doesn't coagulate within 20 minutes, then there's a real problem, and this person needs to go for advanced medical care if at all possible. So maybe give it 20 minutes maximum, but in most cases, it's going to coagulate in 10 minutes. Any type of stinger, if you still have the stinger, honeybees leave the stinger. They commit suicide when they sting you. They usually leave the stinger. Our tendency is to grab at it or push on it, and what we end up doing if the stinger still has the poison sac attached to it, we introduce more poison. Well, we try to avoid that. And this idea of using a credit card or a stiff straight edge object of some sort across the stinger and pull it out. If you can, wash the site thoroughly with soap and water. You can, if you have ice, make sure you have some sort of barrier between the ice and the skin. I'm not sure why this slide says 10 minutes on, 10 minutes off. Generally, what I've learned is 20 minutes on, 20 minutes off. Depends on what sort of reaction you normally have, or you know that you have to a stinger. I'm lucky, I basically have not much of a reaction at all. However, from what I've heard, that you could actually, if you've never had, like I've never had much of a reaction to a bee sting, the next bee sting could be one that would put me into anaphylactic shock. So maybe you want to be careful. We want to make sure the situation doesn't turn into an emergency situation. However, if a person does have known allergic reaction to sting or anything else, for instance, peanuts, that's a common one. Shellfish, that's a common one that people have an allergic reaction to. They may carry what's called an EpiPen, and that's an abbreviation for epinephrine, which is a stimulant. And now I think that they may have 2 doses in one pen. some of you may know more about that than I do, but I know that an EpiPen can be carried by someone who does know that they have an allergic reaction to something, for instance, like peanuts or shellfish or bee stings. You can help them with the EpiPen. You should not be actually injecting them with the EpiPen yourself. You can help them locate it, maybe in the glove compartment of the car. Unless you're trained on the use of an EpiPen, you want to be careful on using it. If a person complains about after they've been injected with an EpiPen, they start complaining about, well, the heart is racing and they're kind of panting. It may be as a result of the epinephrine itself, because that's a stimulant. The signs you want to look for are trouble breathing, noisy breathing, because what we worry about in anaphylactic shock, which is a result of being allergic to something, is the closing of the airway. So we want to go ahead and treat them for shock anyway, right? And after they've been injected by the EpiPen, I want you to know that the epinephrine, the epinephrine only is effective for about 15 or 20 minutes max. So if whatever they have in their system that they're allergic to, after 15 or 20 minutes, they may have a reaction to that, even though they've had some relief from the EpiPen. So the rule is, use of an EpiPen, take them to emergency, take them to see a doctor. Hypothermia, body temperature of 95 degrees Fahrenheit or less. Normal body temperature is right around 98.5 degrees. That's average for the normal person. That's about, so 95 is about 3 degrees below what is normal, okay? Another obvious would be blueness of the skin, blueness in particular, say around the lips. Numbness with uncontrolled shivering. I mean, we all shiver when we get cold, but if you can't control the shivering, that's pretty significant. That's the body's reaction to the hypothermic condition. A little bit later stages of hypothermia, slurred speech. I call it mumbles and stumbles because I've seen it, and it's just like somebody who's been drunk. They have a hard time walking in a straight line. They have a hard time making themselves understood. Their reasoning is confusing. So I call it mumbles and stumbles. If they're walking, it's just like, and they sound just like somebody who's drunk. But what you want to do is you want to take in the totality of circumstances. Are they wet? How many clothes do they have on? What's the temperature? How long have they been out in the hypothermic situation? So all those things can contribute to hypothermia, and it's very important for you to interpret properly some of these signs and symptoms, like the mumbles and stumbles. Mumbles and stumbles may be there actually before the blueness of the skin, the blueness of the lips. Maybe there before the uncontrolled shivering. I've even heard, and I haven't really seen that, but I've even heard that in later stages, people that are experiencing hypothermia feel like they're very warm and they start taking their clothes off. So how are we going to treat these people? Well, if they have wet clothing, well, obviously we want to try to get rid of that, right? Wrap them in a blanket or sleeping bag. You know, these survival blankets, always keep a couple of them in the trunk of my car. You may probably have some of those in your car or at home or in your survival kit. That's something good to have. It's good to wrap somebody with that. If you remove the wet clothing, well, you're going to wrap them with something. Even if they don't have wet clothing, well, then you wrap them in a blanket. If you can, place them in a warm bath, about 100 degrees, 100 to 105 degrees. Kind of hard to tell what the temperature is of the warm water. Just make sure that you can put your hand in the water and it doesn't feel like it's burning you. We're obviously gonna try to protect them from further hypothermia. No alcohol or caffeine. Let me talk to you a little bit about that, because there's some people have had some question about that. Alcoholic beverages interfere with the body's ability to regulate body temperature. It can cause the blood vessels in the skin to dilate, and so it increases heat loss, especially to the extremities. So in hypothermia, the body's reaction is to close down or to decrease the size, narrow the size of the blood vessels in the extremities to preserve the vital organs in the torso. And so the body's trying to narrow the blood vessels. And if you serve alcoholic beverages, or they have alcoholic beverages, the alcoholic beverages is causing those blood vessels to dilate. And so it's increasing the heat loss. So we want to avoid alcoholic beverages. Now, caffeine does the opposite. It causes a narrowing of the blood vessels. So we don't want to give them coffee. We don't want to give them chocolate. We don't want to give them Coca-Cola or any drink that has caffeine in it, because it narrows the blood vessels of the hands and feet, and the body's already narrowing those blood vessels in order to preserve the vital organs. So we don't want to create additional problems, do we? Hyperthermia. We don't have to be in a desert to experience hyperthermia. It depends on your age. It depends on your physical conditioning. It depends on whether you've been hydrating yourself. I've experienced heat exhaustion, and my first symptom of heat exhaustion is a headache. And so that's relatively common. But you can also get a headache, if you got low blood sugar and you haven't been eating properly. So you got to take in totality of circumstances. What are the circumstances? Has this person been outside in the heat? Have they had a hat on? Have they been hydrating themselves? What other sort of symptoms are they experiencing? Heavy sweating. Maybe they're someone who sweats heavily. It depends on how much work they've been doing. Muscle cramps. No, I haven't heard. I know that that's a sign or a symptom, but I haven't seen that very often. Excessive tiredness. Well, it has to be something unique to that person. If they can explain that. Dizziness, nausea, obviously fainting or feeling lightheaded, depending on what the circumstances are. If it's cold outside and they've been outside, well, obviously they're not going to be experiencing heat exhaustion, right? It's good for you to know what your own symptoms are to heat exhaustion, so that you can avoid going into a heat stroke. A heat stroke, the body temperature rises above 103 degrees Fahrenheit. That's a real dangerous temperature for an adult. Not quite so much for an infant or a very young child, but it's a danger signal for us. Depending on it's a danger signal no matter what. If you've got an infection, it's still a danger signal. Rapid, strong pulse, throbbing headache, nausea, confusion, and obviously unconsciousness. So we want to avoid going from heat exhaustion to heat stroke. We want to be able to recognize heat exhaustion. We want to be able to recognize the potential or the possibility of heat exhaustion. So be aware of what the totality of circumstances are. Make sure that you're hydrating, or that other people are hydrating. They have a hat on. They take some breaks. If they're outside in the sun and they're doing work, maybe take some break. Heat stroke is a life-threatening emergency, and heat stroke oftentimes is an unrecoverable state. So what do we do about hyperthermia? Well, let's recognize the signs and symptoms of heat exhaustion. Get the victim to a cool place. Maybe that's just putting them in the shade. If you can fan them, that's fine. If you can get a wet washcloth and fan them, that works pretty well. The thing is, you can't treat the whole body. Put them in an air-conditioned building, if possible, or in a building where the temperature is lower than the ambient air temperature. We want to cool them as rapidly as possible, especially if you think that they are becoming nauseous and becoming lightheaded, because they're approaching a dangerous point. So we want to immerse them, if possible, up to their neck in cold water and cool water. Shower, or we can dose them with a garden hose. Want to get that temperature down quickly. If you can possibly monitor body temperature till it drops down to about 101. You can give them drinks of water, for instance, or if possible, a drink that has things, some of the fluids that you lose when you perspire, electrolytes. Give it to them in small amounts, a few sips every 15 minutes or so, unless they're nauseous, or losing consciousness, obviously. And again, no caffeine, alcohol, or soda for the same reasons I explained earlier. If you can possibly get them to advanced medical care, do that. And to tell you the truth, I don't know why the slide says no fluids for stroke victims. It depends on how serious that stroke is. And I'm not teaching stroke tonight. And that's all I got, folks. Anybody there?
We're here.
We're here.
Okay.
All right, any questions for Mike?
Whoa. It's a lot of stuff.
Have a question, Sherry?
No, I'm just a bit overwhelmed.
Well, one of the nice things about this recording is that you'll be able to access it when it gets posted to the website this weekend.
Okay, I'm going to go to
Stop the recording.
stop the recording.
right.
Come on. Stop the recording.